Hi everyone, I'm Dr. Faisel Sayed.
And I'm Dr. Dan McCarter.
And you're listening to Faisel and Friends, where we believe access to primary care is a right, not a privilege.
Faisel and Friends is brought to you by Primary Care for America, a diverse collaboration of innovators leading the way towards comprehensive, continuous, and coordinated primary care.
Today, we're sharing two different conversations about smarter tech, stronger connections. First up, we're talking with Dr. Paulius Mui. Let's get started.
Well, Dr. Dan, here we are again in Anaheim at FMX. And look who we have. We have Paulius Mui. It's so good to see you again. We first met you when you were a student, and then again as a resident, and now here you're practicing.
Yeah, here I am. Thank you for having me.
That's right. The last time we talked to you on the podcast, I think, was in a barbecue house in Kansas City.
That's right.
So we've done live interviews with you before.
Yeah, I'm really excited to be back. I'm actually so curious to find out what we're going to talk about.
Okay. Well, I mean, we just had somebody, there've been a lot of talks about AI here at FMX, and I think you're even doing one of the talks about AI here.
I just wrapped up one on Sunday.
Okay.
Yes.
And so a lot of people have more gray hair like us, and we're interested in knowing what the future of healthcare is, and we think you're probably better able to tell us where things are going or where you see things going.
Yeah, well, I'm not sure if I have the crystal ball, but what I do see what's happening is that a lot more physicians are at the table, and, that's really encouraging. I don't think, I was not really around when EHRs were rolled out, but I don't know if people really gave these types of gatherings or talks and shared with each other how to evaluate these tools, right? They were kind of just handed to us. And now I think the directionality of who gets to have a say in this is really changing. And I think a lot of younger people are leading those efforts, which is really cool.
I'm constantly told by my children that I'm not using AI properly. My kids tell me that, Dad, you use AI as if it's Google. It's got so much more potential than that. And they're right. In the clinic, now that I've started opening up my mind to the possibilities with AI, I mean, we're using it for case conference presentations. We're using it in so many different ways to make just patient care much more efficient. One of the things I'm seeing, though, is that there's some groups of people who are using the AI to get their work done quicker, but the relationship time that many of us who have the gray beards, the white beards, that we view the AI, that all the time that's saved with all the manual work as more time with the patients. One of my concerns is that with some of the more younger people is that if they're viewing it like, hey, this is a way to make all of my work shorter, including the patient care time. What are you experiencing?
Well, I think I do hope that there's a lot more humanity infused in just our care experiences, because if we look at what's kind of happening, like let's just even zoom out, like you were just commenting about who's using AI and who's not using AI. This I observed from a talk by one of the co-founders of OpenAI, Andrej Karpathy. He gave this talk, and he kind of reflected that technology, like powerful technology, has generally flowed from like government to institutions and then to people. And like one interesting thing about AI is that it's actually, the flow is in a reverse order, where consumers and patients, our individual people are getting access to these technologies before the institutions or the governments have figured out a way to wrap their heads around, right? And so I think that's kind of what's shaking this whole thing up. And then, and I think there is real potential to actually create more space for people to make healthcare a more human experience. Because also what's happened with EMRs, that space, I think, between the patient and their physician has just been getting more crammed over time. And so everything is going into that space that's really tiny. And I think now a lot more solutions are developing to help with things in between visits, or all the paperwork that needs to get done, that's basically supporting the time together. And so I think that if more physicians are part of these conversations, they're at the table doing stuff, we're going to kind of like recalibrate to what's important.
Bring the relationship back. Yeah, we should definitely. I mean, we were just talking earlier today at lunch about there's a lot of fear with AI, and similarly to like other technologies, great groundbreaking technologies that came, like what's going to happen if we get rid of all the horses with this automobile? Like I kind of feel like we're at that time right now with a lot of the doom and gloom with the AI. I mean, we can really use it to restore a lot of the humanity. And I'm excited to see about all the different roles and jobs that are going to come. But now, like when I saw you last, you were in residency. Mm-hmm. So since you left residency, what are you doing now?
Okay, so it's been a minute. So I got recruited away to move to Texas.
Oh.
So I was there for a couple years. And I really was lucky because I didn't really have a job description, and my directive was to make things work with technology. So I built out an innovation team for a practice that had about 50 locations. And so the scale was a bit larger. So we got to basically build our own EMR. We built a lot of patient-facing, clinician-facing, back office, front of the house tools. And I was lucky enough to just learn how to lead engineering teams and product. And a lot of it was on the job, kind of learned by doing. And then I always had the itch to do my own thing. So this year I saved up and I'm bootstrapping a company and basically doing that full time. And I also did not want to give up medicine. So I started a virtual primary care practice.
Awesome.
And that's maybe 10% of my time. And it's not something that really generates cash because I've set it up where patients can pay what they can. So it's really like a sliding scale. And generally my patients are the ones that don't have insurance and like have never had the experience of having like a family doctor access. So, a doctor they can text and ask questions. And because it's a virtual practice, I can't do everything. But I'm able to help with 80, 90% of the things that they encounter. So there's a lot of care coordination for them. It's a lot of time being able to make up for touch in different ways. So if they have a symptom that's ongoing, instead of having to make a no-go decision during the 15-minute visit, I can actually just have them text me throughout the day and see how things evolve. And they're so not used to it. And then I get to actually try out different technologies in this clinic, and I get to test the different AI technologies because, I own the clinic.
Yeah.
So then you don't have a lot of bureaucracy layers to experiment with that. So that's been really interesting and rewarding. And, how there are all these interoperability tools and you can get ADT feeds when when a patient lands in a hospital or not. Well, my ADT feed is the patient texting a selfie that they just like had to go because get their gallbladder taken out, turns out, and so it's really a special way to just connect with people, and it's not realistic. It's not scalable, but it allows me to have a lot of fulfillment and use that to hopefully build better tools with what I do with the rest of my time.
So, you hear people in the industry talking about AI is going to take the place of primary care. Mm-hmm. And I feel like it's going to broaden what we do and maybe take the place of some unnecessary consultations that are happening right now. What are your thoughts about that?
So the way I think about this, I actually just published an article yesterday on this topic, and none of these ideas are my own, but I think it's kind of taking what's happened in other industries and learning from that. So Anthropic is one of the big AI companies. They make the chatbot Claude, and they've put out this paper called the Anthropic Economic Index. And it's a study of how labor markets and occupations are transformed with technology, because they want to understand how does their chatbot change jobs. And what they're actually looking at, instead of looking at how an entire occupation changes, they look at how different tasks within an occupation and then across occupations change. So for example, if you look at like visual pattern recognition, radiologists do that, but so do photographers and so do other people. And so like that task of visual pattern recognition might be augmented or automated with AI. And so that's kind of how Anthropic studies how their technologies are going to impact labor markets. So why aren't we doing that in primary care? And so the way, and this is really like at the core of what my company is doing, is the ability to actually measure and then develop the skills that are related to the tasks that we do. And we've just never been able to look at things this way because traditionally it's either been the payers that tell us what metrics to measure, right? Or like that need to be tracked because they want to look at population level statistics. Sometimes the practice managers want to look at RVUs, but none of these things actually, I think, get at the core of what we think good care looks like. Like when doctor to doctor talk to each other and when they ask like who should they send their family member to, it's not who bills the best. It's not who has even like the best quality metrics. It's like someone who genuinely cares. And there's a lot of EQ and obviously some IQ to it. And I think now is really possible to measure that.
Wow.
And the idea is like not to measure for the sake of measurement, but to measure so that you know how you can actually improve. Because right now, if you go to an organization and ask which of your clinical team members struggle, most cannot answer that question.
Yeah, it's like we've been building slowly. Like there was somebody who was doing a job with pen and paper, but now they're still doing the same job, but with a computer and clicking in a couple different places, and then that evolved to. But then you've got this coming through, and you're just like, well, hey, we didn't need to be doing any of that in the first place.
I completely agree. And it's kind of funny how we have check boxes and we have humans doing the check boxes, and then we have other humans checking if those check boxes were done properly. And this is madness.
It's still going to be a valuable skill to be empathetic. I mean, do you think the AI is going to take the place of the empathy, or do you think you're still going to need that human interaction?
I mean, I would love to say that this is what's going to make us different from all the computers, right? Is being flawed and vulnerable, and how do you replicate that sensation of being seen and feel heard and all of that, right? Because I mean, what we do in family medicine is we often like witness a lot, and we see the suffering, we see the different celebrations that happen and recoveries and healing. And so if technology can find a way to witness and then, replicate that, maybe someone's going to be doing that. But, I think that ideally we become more human and like remove all the different distractions that we have that right now get in front of us, especially in healthcare.
I mean, what a crazy couple of years in healthcare. I mean, I remember just with the direct primary care movement, and then now in January, $150 a month is they can take that out of their health savings account. It's amazing. Gets rid of all of the headaches. And now you've got these tools that's getting rid of all the headaches that were there from before too. What a crazy time. My goodness. Well, Paulius, thank you so much for taking the time to come have a chat with us over here in the middle of this conference with all these people walking around. If you have one message you'd like to give to an up-and-coming medical student or even an intern or family medicine resident about these next couple of years, what would that be?
I mean, I think that maybe this is for anyone, I think, who is involved in care delivery. I would love for them to involve learners in their everyday just taking care of patients or building up a practice or learning, because I think when you're in a position that you're trying to teach someone else what to do, you're forced to be sharper yourself. Yeah. And I just think that we want to try to support the people that are coming up. And I want to try to find ways to contribute to that. And so I like to work with students and residents and, contribute in such a way that they're going to do the same and pay it forward. And so I just encourage that to be, I think, more widespread.
Oh, thank you so much for joining us again. This was great.
Thanks for having me.
To continue the discussion, next we're talking with Dr. Gina Engel.
We're continuing our conversations over here in Rapid Fire, which is quite exciting. We're used to normally spending, a half an hour, 40 minutes talking with each person, but we're at the conference here at FMX conference here in Anaheim, and now we're here with Gina. So welcome, Gina.
Thank you.
So with everyone, if we're asking everyone to introduce themselves and let us know where you work and what you do.
Yes. Well, I'm Gina Engel, and I'm a family medicine doctor, of course, and I see patients about half the time, and the other half the time I work with our ACMO at UVA Health and oversee our primary care practices primarily.
Wow. So how long were you practicing before you got into the leadership role at UVA?
Oh, that's a great question. So I was at VCU in Richmond for about 5 years, worked with their residency program there, and then I've been at UVA Health now for just over 20 years.
Wow.
And in various leadership roles all along the way. Probably the last 10 years I've been doing the most work as medical director of our adjacent physicians group practices, and then in the last 4 years as ACMO.
Wow. So you've seen all the changes, especially at UVA over the last 20 years.
Yes.
When I did residency, I was part of the class that transitioned from doing all the paper. We had the paper charts, and then we had to switch over, and they promised us all this amazing stuff with the EMR, and I was in residency when that happened. And I remember in our OB rotations, we would have the folder in front of the door. We had no idea who was behind the door. You just pick up the folder, you look to the left, you get your face sheet, you have 3 charts on one piece of paper, and we were quick. And then we went from being able to see like 12, 15 patients in a half day to maybe 2 or 3 because it was just so clunky. But now, with all these advances in the last year, I don't feel like it's been clunky. What's your experience been like, especially with the artificial intelligence?
Yeah, well, we've had, I think, a very good experience. We're currently using an ambient AI, and the amount of time to document has really decreased. And I will say that personally, the cognitive burden of trying to capture that conversation while I'm trying to think about what my plan with that patient's going to be, it's just dramatically reduced. So that at the end of the day, and if I've forgotten something or left it out, that ambient AI has captured it. And so I can refer back to some of those things. And so not only do I have less time in documentation, but I have more time to really think about what I want to do for that patient. And for better or worse, I've had more time to reach out to specialists to, fill in some of those knowledge gaps or to help patients connect with their specialists and get them in for their care in a more ongoing fashion, I think.
We've had some other guests talk about AI, and but most of them are talking about the impact for an individual practice or an individual provider. And yet, in your role, you oversee probably 100 practices, close to it. What have been the barriers to the implementation of AI? Who has struggled with it that you didn't think would struggle with it, and who has done well with it that you're surprised that they're doing well with it?
That is such a great question, and I think we're still learning some of that. But I will say, for our very early adopters and that next level, it's been super simple. They have taken to it without any difficulty. I've been a little bit surprised, actually, even within my practice. I have a couple of young people who I would have thought would have really enjoyed this, that either 2 have not used it and 1 started using it and stopped. And so I'm still trying to figure out or understand a little bit better why. In the case of very new providers, clinicians, I think it's because they're thinking a little bit as they're typing. It maybe gives them that time that they're organizing their thoughts. And so I think that we might want to revisit these providers to, in a year or 2 to say, okay, are you ready now to do the ambient AI? And then I think there's a different level of, for our people who are not early adopters, that we probably need to go through the organization again, because now that they're ready, hopefully they've heard that people are having good success, but they're probably the ones, even though this is fairly easy to use, they might want some help. They might want somebody to sit with them and to, just see how it works, and then maybe be able to take that on.
Have you seen, so you also do a lot of work, obviously, in with value-based care, and the country has moved strongly in that direction, with not just the touches, individual touches or individual interactions with each patient, but also the meaningful interactions. And so a lot of times the people who do a lot of that busy outreach work, they just, they're trying to basically hit a metric. Like, I've touched so many people, but in the value-based care world or in the outcomes-based world, it's not just that. So what have you seen with all these new advances with the care teams themselves?
Yeah, it's, again, another very good question. And I think we're at the very beginning of that. Dan and I work together in the value-based care area, so you'll have to ask his opinion as well. But we're starting to understand, a little bit of how this can help our care teams. But we're not using this for our nurses yet. And I really think that's going to be the next level, is how do we build in tools for other members of our team. So currently we're using it for providers only. But I think there are things within our EHR that we're not using. There are definitely things that we need to do for our nurses and our maybe care coordinators.
Yeah.
And then really enable them to reach out. Because I think what your question gets at in my mind is, we're really good when the patient's in front of us. So one by one, we can do a really great job. The problem is we need to reach, a whole different level of people, and we're not really there yet.
Right, and the primary care provider can't always be the default. Everything has to go to them. It seems like the two defaults in healthcare right now is you've got to ask your primary care provider, and if they're not available, or you don't want to wait, go to the emergency room. And both of those don't necessarily give the best outcomes. We're not empowering the rest of the team to do the work. I don't know what the answer is. You think about that, and it's Dyke Drummond, who we know, who's the happy MD, talks about burnout. And I was listening to one of his podcasts recently, and he was talking about that we mislabel dilemmas as problems. Problems have a solution, right? A math problem has a solution. 2 + 2 is 4. Dilemmas can be managed, and so many of the issues we're dealing with team members in healthcare are dilemmas. They don't go away. We're never going to make them go away. How do we manage that to decrease the burnout, to do that kind of work?
Right. And I think some of what we're finding, whether it's with AI or within our electronic health record, is how do we make sure that we build this so it really, is an aid to our providers, clinicians, care teams, the works, and it really enables people to do the best work every time, and leads us that way.
Right.
Yeah, I miss the relationships. I remember when we were still working in the paper chart world, the physicians would all meet with each other. We'd all meet with each other at breakfast. We'd have ideas. We'd run them off with a specialist. Hey, I'm kind of thinking about doing this. Or we'd make rounds in the morning, and, there would be a tech who would come and tell you something. So this happened last night. And, oh, okay. It wasn't, we didn't have to look in the medical record anywhere. They would all know that we're making our rounds, and we'd all be there. And now we focus so much on the doctor-patient relationship, but I feel like we've come so far away, not only from that, but from the doctor-doctor relationship, the doctor-team relationship. But now with all these tools, I feel like this is like the best time for restoring a lot of the relationships that got transactionalized, if that's even a word.
Yeah. Well, and I think that's very true. And, I also think, of course, COVID played a big part.
Oh, yeah.
And so we do a lot of things virtually, which is great. However, I think we do need to start bringing some of that back. Maybe the day-to-day, we need to meet quickly for 30 minutes in order to continue the value-based work, or, how do we, move projects forward. But I really think that getting together more often is going to be even more important, because I agree with you. We are missing those relationships, and I worry about keeping our residents connected and keeping, others, and that's going to help us retain really good staff and help people feel supported.
Yeah, we were talking earlier, and like one of the observations I've seen with all of these advances is that the people who, who have grayer, whiter beards now, who got into this because, we love people, and we love helping people, and we love working with people, all these tools that have freed up, because none of us like being on this and the computer and the patients right there, and we're not even looking, but none of us got into that. But when you have these tools that have freed up time, we feel like this has freed up time for us to have better relationships with the nurses and the care team, better relationship, of course, patient, even doctor-to-doctor relationship. It's never been easier. But then I worry, though, about the younger generation who may view this as a shortcut, all these things as a shortcut, that, well, they've already been brought up to have little time with care team members and patients, and now they've got this tool to make their lives shorter, that they're not going to use the freed up time to invest it in the relationships.
Well, and I would say, at least an observation I would have is, I think they are getting to get home to their families sooner, because a lot of them, again, and, my kids are now in college and whatever, but, they have frequently younger families, children, that sort of thing. So I do believe they are getting to do some of that. So I'm hopeful that maybe some of the burnout in that regard will be less. But I do think there's some benefit from building those connections at work. And some of that does take a little bit of time, whether that's lunch together or, just other various times through the day, solving problems. How do we make our workflows better so that tomorrow when I come to work, it's going to be smoother. So I hope that we can figure out ways to do that creatively.
Yeah, I feel like a lot of it, it's amazing. The rollout has just been so smooth. The only thing I can compare it to is I remember growing up, I remember going to computer shows with my dad, and we would go to the computer show, and we would get, instead of a 17-inch monitor, we'd get a 19-inch monitor. Instead of a 14.4, whatever the modem was, it was like a 28.8, and we would tweak and modify the computers, right? And then the iPhone came, and then it was just so easy. You didn't have to think about it too much. It just did most of the work. And I kind of feel like finally, out of all these other industries have figured out how to, financial industries have done a great job with managing all of our personal private information, but in healthcare, we're still dealing with fax machines and things. And then now here you've got this, what an era to be living in, where we've got all these tools making our lives so much easier. That's what it feels like to me.
Well, and I think that the ambient AI that we're working with is really just the ground floor.
Yeah.
Right? I'm seeing more and more tools that help summarize the chart and, can find things that, we spend a lot of times, and I feel like we've talked about it at some of our meetings, like this, searching through the chart. It used to be a paper chart, which meant you could flip through it, but when it's an electronic medical record, you can't really do that, right? You have to point to each of these things. So I think, again, many of these tools are going to continue to free that up.
Well, and then how we share information across organizations. Used to, when it was the paper world and somebody sent you a bunch of Xerox records, you were still going through sort of the same thing. But there's a big difference if the patient is in your organization versus it's somewhere else and the information's getting shared across. So I think there are a lot of opportunities there to make it easier for us to see the information in a way that sort of brings it together when we're with the patient. One thing I was thinking, and I know we're getting close to the end of the time. So Faisel flew in this morning from Tampa, Florida, and went through withdrawal because he didn't have the internet for 5 hours. And so I'm wondering about the younger doctors that are struggling with this. A lot of people have gone through training thinking that clicking is their job. And if you take the clicks away, do they know what to do in that time frame with the patient if they're not clicking the whole time?
I think that's a great, observation. And I think, one of the things that, again, as an older doc, right, that I'm, really enjoying that now I can just look at my patient and I can, get all those things from the patient, like their body language and their expression, and and I can empathize with them more because I'm not feeling like, well, but I got to capture this for the record. And so maybe that is going to be another piece of what we need to help residents understand is, the amount of information that they'll get from their patient, but also that connection. I just don't think there's any substitute for it. And, we're at AAFP, but that's why I went into medicine, is to be able to have the relationships with my patients and with my team members, right? I want to be close to my nurses and understand what my patients and my team members are going through, and that makes all the difference for me at the end of the day.
Wow. So for the students, like we have students, we've got residents who are up and coming. If you had to have one message for them, we've had a wonderful career coming up over here, starting as a family doctor, getting into leadership, and then having this leadership role, having such an incredible influence over 100 clinics. My God, as a family doctor, it's incredible. If you had a message for an up-and-coming student or a resident in family medicine, what would you have to say to them to look forward to in the next 1 to 2 years?
Yeah, I would say that it's really all about the people. Take time. You have to learn the science. You have to know the protocols or, the resources, that sort of thing. But, it's really about the people, and that's what's going to keep you connected and keep you coming back. And that's what we do it for.
Oh, my gosh. Well, Gina, thank you so much for taking the time to join us today. This was a great conversation.
Absolutely. Thank you.
Yeah, thank you.
Thank you so much.
What are your thoughts on smarter tech, stronger connections? You've heard ours. Now we want to hear yours.
Email us at faiselandfriends@gmail.com, and your question could be featured on the podcast.
If you like this episode, leave us a review and tell us how we're doing. And don't forget to subscribe wherever you listen to podcasts so you never miss an episode.
Connect with us on social media by following Faisel and Friends.
And follow Primary Care for America on LinkedIn and Twitter.
I'm Dr. Faisel.
And I'm Dr. Dan.
And thanks for listening. This podcast is brought to you by Primary Care for America Collaborative and produced by Split Prism Productions.